All right, and then go through and do some introductions. Sean, if you wouldn't mind introducing yourself to the group.
Bonjour, hello, my name is Sean Middleton. I'm a MSW social worker, and I work in the Circle of Cares grant over here in behavioral health building.
Dr. Robbie, I see you have your video on. Are you able to introduce yourself? Is it going to work?
I think I had Teams running at the same time before. My name is Kari Robbie. I'm a family practice and addiction medicine physician. Rich.
Nikki?
I'm Nikki Jardina. I am a RN at NAC, and I do infectious disease care coordination.
And I'm Michelle Corcoran, for those of you who don't know. I'm the nurse manager at NAC for the MAT program. Normally Tina does this work and Dr. Robbie, but I'm filling in this week, so bear with me while I try and figure out what I'm doing. I see a lot of names that are new, so that's super exciting. Thanks for joining us.
Hi, I'm Heather. I work at the Indian Health Board. I'm the opioid educator. Sorry, I can't put on my phone right now because I'm taking a call, but I am right here with you. So thank you.
Wonderful, wonderful. Is this your first time joining us?
Yes, yes.
Oh, welcome. That's awesome.
Thank you.
That's awesome. I'm going to share my screen. See if I can figure out what I'm doing here. All right, so this is Midwest Tribal Echo. As you know, we're going to be talking with Swetha Pradeep, a pharmacist perspective on polysubstance use. So pretty exciting stuff. Here's the agenda. Fred did not do the prayer and land acknowledgement. Sorry, Sean. We'll go through and do our guidelines and announcements, and then get right into the didactic. So Zoom guidelines, we all know this. One thing I do ask everybody, whether you've been here before or not, please introduce yourself in the chat. We need your name, your email, your title, organization, that sort of info. So if you could do that, that would be great. Turn your camera on if you can, or if you want to. Mute your microphone when you're not speaking. There is the chat. There's also the hand raise function, and no, patient information. So for announcements, we've got Melanie Nadeau is joining us on the 17th, centering culture in the treatment of OUD. So that's going to be pretty awesome. And then in September, our first session is from Marilyn Zimmerman, who's the National Native Children's Trauma Center staff. Not sure what exactly the topic is going to be, but just based on where she's coming from, I'm sure she'll have some good info. Other echoes, you guys are more than welcome to check out the Northwest Portland Area Indian Health Board. HCMC or Hennepin Healthcare has an echo. The Indian Country Echo, that's based out in Portland, but lots of categories and topics. So it's pretty cool. Their website even has a lot of resources. Stratus Health, who we partner with for this project, they do an echo session with Dr. Bell and Dr. Devine. So that's also available, and you guys can reach out if you want more info. We do have, there's a new online resource. So Center for Opioid Resources and Education, or CORE. Looks like the website here is listed. I'm thinking maybe there's a bit of a typo there. If you want links or anything like that, let us know and we're happy to send that stuff out. What is this one? Oh, we sent out a survey. Thank you to everybody who participated in that. We are going to go through a few questions at the end, just kind of chat as a group. But I think the survey is closed now. case presentations. Case presentations, you know, that term sounds a little formal. Really what we're looking for is just discussion topics, right? Things you guys want to chat about, whether it's a particular patient situation or something that you're seeing in your practice. Let us know, and we will certainly chat about that during a session and you know, get feedback from others. And really, these case presentations are a way for us to learn from each other and learn together. As we know, stuff is changing all of the time, and there's no way that we can all keep up on our own. So this is a way for us to help each other out. Continuing ed. If you tell us who you are and give us your email address, you're going to get an email with a little survey. That is what you use to say that, yes, you attended, and then you can get continuing education credit. If you don't need continuing education credit, you don't have to do anything with that post-session survey email. And I'm going to stop sharing, although I don't know how. There we go. And now, Swetha, are you ready?
Yes, just a second. Okay, I think it should be working. Great. Well, thank you for having me today, to the whole group and to the team here at NAC that invited me. I'm Swetha Pradeep. I'm the clinical pharmacist at NAC, and I work with the network of FQHCs here in Minneapolis called FUN. So thank you again. I'm really honored to be asked to speak with this group about the role of the pharmacist and also the pharmacology of polysubstance use today. I'll have some time at the end for questions. If anybody has anything, they can certainly drop it in the chat or we can talk at the end. And I know I have some pharmacist colleagues on here as well, so really would like to hear other people's perspectives too on this topic. So by the end of today's presentation, you'll be able to understand the pharmacist's role on the care team, define the mechanisms of methamphetamine, cocaine, and opioids, and identify the pharmacological interactions between certain substances of abuse. So first, I just want to highlight the role of the pharmacist in the care team. So what does a clinical pharmacist do? We are the medication experts on the care team. Our education includes at minimum a 4-year doctorate degree and some optional additional training to specialize in different fields. And this postgraduate training can be 1 year, 2 years, typically in different areas, including primary care, psychiatry, emergency medicine, critical care, cardiology, and so on, to really kind of hone in those medication management skills in those different areas. And pharmacists may work in a variety of different settings. You might think of a typical traditional dispensing pharmacy, but pharmacists are also in the clinic, like me here at NAC, in the hospital, at dispensaries, at insurance companies, in research, education, and more. A clinical pharmacist provides very basic level comprehensive medication management, which is kind of what it sounds like, comprehensively assessing all of a patient's medications or supplements, vitamins, and so on, regardless of what they're used for. And so we kind of follow this process to review medications, reconcile meds from different places or different providers, help to choose the best treatment options for an individual patient's needs. For example, if they have like poor kidney function or they're taking different medications or substances, trying to incorporate that into the plan. Also help to monitor and help reduce any side effects and support medication adherence and medication access. In general, pharmacists are collaborating with the entire care team to provide patient-centered care with that lens of being the medication expert. So I have a couple of slides here of what people should ask their pharmacist, kind of thinking about different roles. And I have some examples of questions that I've been asked from patients. So in general, really anything medication related, prescription, non-prescription, and so on, is a good question to ask a pharmacist. So for example, does this supplement interact with any of my prescription medications? I started feeling dizzy when I started this new medication. Is that a side effect? My kidney doctor prescribed me a new medication. I don't know if it's good for me. I can't afford my medication. Are there any coupons or alternatives? Can I drink alcohol while taking this medication? Which vaccines do I need? These are just some examples, like I said, of patient questions for a pharmacist. Clinicians, again, can ask anything medication related. Some examples here. My patient just left the hospital and has no idea what medications they were given. Can you teach them about their new meds? This patient's kidney function has worsened. Do we need to adjust any of their medications? Is this patient a good candidate for starting naltrexone for alcohol use disorder? This patient is on 2 blood pressure medications and their blood pressure is still high. What should we do next? My patient cannot afford their inhaler for COPD. What can we do? Is this medication safe to use if someone is breastfeeding? And finally, some questions that non-clinical staff could ask their pharmacist or their pharmacist team member. Again, anything listed on the previous slides is totally fair game. Some questions that I've gotten include, my client doesn't understand their medications. Could you help explain them? My client sees a lot of specialists and isn't sure if their medications are correct. Can you review them? My client can't afford their medication. Are there any coupons or alternatives? My client doesn't have a ride to the pharmacy. Can their medications be mailed or delivered? And my client struggles to remember to take their medication. Are there any tools available to help them? So really a wide variety of things that pharmacists can help with. Pharmacists can also help in harm reduction. I think the primary instance of this is educating and providing naloxone to patients, families, and community members. Also helping to navigate substance use while managing any comorbid medical or psychiatric conditions. I work with a lot of patients who have diabetes and who are also using alcohol at the same time. And so we talk a lot about safely, like taking your medications, checking your blood sugars if you are going to be drinking alcohol, and kind of making sure you're taking care of your body the best that you can. I also wanted to highlight some work that the University of Minnesota College of Pharmacy in Duluth is helping to distribute fentanyl testing kits in rural Minnesota as part of this community-based opioid prevention education group. And in general, pharmacists can help with reducing the stigma surrounding substance use and treatment. And again, just being part of the care team, being supportive of the patient and their goals. So transitioning into some more like technical information here, I'm going to talk about dopamine and the reward system and how that's related to different substances that can be misused. I certainly do not claim to be an expert in like neurobiology, so I'll try to keep it pretty high level, but certainly we can discuss any questions that might come up later as well. So there's some major dopamine pathways in the brain here, and the ones that I've highlighted here are considered reward pathways, which you may have heard of before. And so dopamine, so these different neurons, different brain cells kind of go through these different pathways here, and these, when the dopamine is going along in these different ways, it is responsible for different behaviors associated with learning, habit formation, and addiction, depending on like where in the brain the dopamine is traveling to. So stimulating these pathways kind of reinforces that association between a particular stimulus and the reward that follows. So the blue pathway here, the mesocortical pathway, that's kind of reinforcing things related to memory and learning. The green little pathway here is reinforcing kind of like movement, behaviors, habits, things like that. And then the mesolimbic pathway is the one that's talked a lot about with addiction, is the pathway that's following along with pleasure and reward seeking behaviors. So along each of those pathways, to kind of go even more on a granular level here, what is dopamine actually doing in the brain cell, in the neuron? So dopamine is released by a neuron into the synapse, which is the gap between the brain cells, and that's kind of how the brain cells communicate. Dopamine goes into this gap, the synapse, and binds to receptors on its next door neighbor cell. And that's how the signal is carried forward. Dopamine in normal processes is usually recycled back into the transmitting neuron by a dopamine transporter. So to prevent kind of like this excess of dopamine buildup in that synapse. And we'll talk about in a little bit here how different substances can kind of affect this pathway here. So I'll start with methamphetamine, which is this little molecule here. So the mechanism of action for methamphetamine is to directly increase dopamine's action. So like I talked about on that previous slide, that action of like carrying the signal forward, it directly will increase that and cause euphoria. So it does this in two different ways. It helps by causing the release of more dopamine from the neurons and also preventing the dopamine from being removed from the synapse. Methamphetamine lasts quite a long time in the system. It takes about 12 hours for half of the amount ingested to be removed. So people might have that effect for a long time. And you can see it listed out here. There's a lot of physiological effects, which I'm not going to read off, but you can certainly see different short-term effects and also long-term effects with chronic use. So methamphetamine increases dopamine in the brain in multiple ways. This picture is similar to the one I used before, which I'll kind of go through the different steps here. So monoamines, which are the different neurotransmitters. Here I'll be specifically talking about dopamine. So dopamine is moving from its little storage vesicles out of the cell. That's kind of the first way that methamphetamine is working. It also blocks the transporter that is removing and recycling dopamine from the synapse. So again, that's going to lead to more dopamine in the synapse. Methamphetamine also causes fewer dopamine transporters to be expressed or be available on the cell surface. And so again, that is just fewer transporters that are available to remove that extra dopamine from the synapse. It also prevents the enzyme that breaks down dopamine from working. So again, we're kind of building up more dopamine in that way. And finally, it is increasing the activity of the enzyme that it makes the precursor to dopamine as well. The next substance here is cocaine. So cocaine works a little bit differently, similarly and differently to meth, in that it is mostly blocking the removal of dopamine from the synapse, which can cause a euphoric effect. Separately, it also is blocking sodium channels to block nerve conduction, to have this anesthetic and some of the cardiac effects. Historically, cocaine has been used for this medicinal purpose for this anesthetic effect, and that's how it is working, by blocking those sodium channels to block the nerve signal from moving forward. And cocaine, it doesn't last in the system as long as the meth does. It takes about an hour for half of it to be removed from the system. And again, you can see the different short-term effects here and also the long-term damage that can be done with chronic use. So you can see here, cocaine blocks the dopamine transporter, which is the purple thing, and the green circle on the right. I thought I could have a little like pointer, but I don't know where that is, which is okay. Oh, maybe it's this, I don't know. So cocaine is blocking that dopamine transporter from removing and recycling dopamine, again, leading to that buildup of excess dopamine in the system, and causing like a more intense effect of that signal moving forward, going along that dopamine pathway, doing the whole reward pathway and reinforcing behaviors. The last substance I'll talk about today is opioids. The picture I have here is of heroin, I believe. And so opioids work a little bit differently from the last two stimulants that I talked about, in that it more indirectly stimulates the release of dopamine in the brain. So it's binding and activating these opioid receptors, which I'll show you on the next slide, ends up causing a higher amount of dopamine to be released than otherwise. And here again are some of those short-term and long-term effects that you can see on the screen. So like I said here, opioids work a little bit indirectly to increase the dopamine release. So the mu receptors, which the opioids are binding to, is on this GABA neuron. And usually the GABA neuron actually prevents dopamine from being released. But when the opioids bind to that GABA neuron, it makes it so that the GABA neuron cannot do its normal job. And so there's no inhibition on that dopamine release, which means this kind of disinhibition leads to an increase in dopamine release instead. So knowing that all of those mechanisms are happening, I'll kind of talk a bit about polysubstance use or concurrent substance use, which is common. SAMHSA put out this paper just kind of with the statement that if a person's having problems with one substance, they're likely using and having problems with other substances as well. So it's important for us to be aware of that and talk about it with our patients and clients. So this is data from 2019 from SAMHSA on kind of concurrent substance use. And so the blue bars on the bar graph are for people who have used any past year methamphetamine use. And you can see for there's a high rate of concurrent use across pretty much all of these categories between marijuana, opioid, alcohol, and cocaine as well. The last two graphs are the rates of use in people who have major depressive episodes or serious mental illness. So a high correlation there as well. So the risks of polysubstance use are primarily related to these compounding or kind of dopamine and serotonin effects piling on top of each other. I didn't really talk about serotonin that much in this presentation at all, but it is also kind of another neurotransmitter that's being released in the system that can have some more physiological effects that can be detrimental to people. So if people are using methamphetamine and cocaine together, sometimes it's called overamping, which is worsened by sleep deprivation and dehydration. It also is increasing their risk for heart attack, seizure, stroke, hyperthermia, or psychosis. If people are using stimulants and opioids together, often the stimulating effects of cocaine or meth are actually offset by the sedating effects of opioids, which may lead to higher intake of opioids and increase someone's risk of an opioid overdose. The combination may also so the use of the stimulant may also relieve the opioid withdrawal symptoms as well. And so this table here just talks about the combination of different substances and some of those potential adverse effects. You can see on the left, using multiple stimulants can cause these problems like serotonin syndrome, psychosis, anxiety, cardiovascular problems, and so on. Using multiple depressants like benzos or alcohol can lead to excessive sedation, respiratory depression, fatal overdose, which can be, or non-fatal overdose, excuse me. And then the last category there is using stimulants and depressants together. So if someone's using meth and alcohol together, can lead to cardiovascular problems, respiratory infections, dehydration, and so on. I when I was putting together this presentation, I came across this recent publication that I thought was kind of interesting to share with the group if anyone wants to look into it on their own, about dopamine supersensitivity and how that could be related to opioid stimulant co-use and opioid relapse. So it's an untested hypothesis. It hasn't been studied in humans or animals, but they kind of compiled a lot of different information of other like neurochemical and neurobiological mechanisms from previous information studied in humans or animals. And so their hypothesis is that if for people who are physically dependent on opioids, it can actually lead to this change in their dopamine system. And because of that change, if someone were to go through withdrawal from opioids, it can actually lead to decreased dopamine levels and increased dopamine receptor sensitivity. So even if they have less dopamine floating around, it actually has a greater effect despite those fewer dopamine receptors. So more of this dopamine effect means that opioid stimulant co-use may cause greater euphoria, but also some potentially harmful effects as well than either of those drugs alone in those who have this opioid physical dependence as well. So just to wrap up here, pharmacists are the medication experts and can help patients and staff navigate a variety of medication concerns. Methamphetamine, cocaine, and opioids all increase dopamine levels, and that is mostly what is affecting the brain's reward pathways. And those overlapping mechanisms of the concurrent substance use can lead to adverse effects throughout the body. So that's everything I was going to chat about today, but I see we have a lot of questions in the chat here that we can address together here.
Swetha, do you want to stop sharing your screen? And then we can try to have a discussion. Do you want me to read questions out to you, or do you want to read them?
You could read them out loud, and then and if there's certainly looking like this, there's probably some questions I don't have the answer to. So I'm really curious to hear other people's responses as well.
Yeah, absolutely. So the first question I see here is about the meth half-life being 12 hours. So why then does the meth psychosis and paranoia and that sort of thing last so much longer? So Sean says, is that due to the drug-related damage left by use? I ask because some folks have talked about the need to detox from meth for an extended time to help with the psychosis. And I think we see that a lot, right? Where even though people stop using meth, they still have those psychosis symptoms for a long time. Do you have any thoughts or information on that?
Yeah, I think I think from what I've learned is it mostly probably is related to some of the damage left to the system, but also just thinking about with pretty much any substance in terms of like, so 12 hours would be how much it takes for half of the substance to clear. And so usually when we're thinking about like any substance like being removed from the system, whether it's like a medication or a substance, whatever, we usually say like 5 half-lives is how much it takes to like fully eliminate from the system. So that could also be potentially related to it as well. So after like one use, that would take maybe like 60 hours potentially to like fully clear from their system. But I think that might be contributing to it as well.
Does anyone have anything else related to that, or?
I do.
Yeah.
I was just going to add that maybe underlying conditions as well, which can be exacerbated by the meth. And so, if they're detoxing, it might take, a little bit more time to get, whatever's going on to kind of stabilize.
When you say underlying conditions, do you mean like a
Like
mental?
mental health, yeah.
Yeah, that makes sense.
Yeah.
I feel like the patients that that have had really had really the full, the meth psychosis. I feel like it's a lot of them. It definitely clears when they stop using, but not necessarily right away.
Yeah, I guess I imagine, it disrupts the way that these chemicals are being made and used in the brain, and kind of retraining the brain takes a long time.
Yeah, and I think there's also evidence that with like chronic use, kind of like you were saying, Michelle, like people's like the pathways in their brain are altered, and that can be kind of with anything, with any repeated behaviors or so on, that could certainly affect it too.
Dr. Myra, do you have a question?
I do. I'm just laughing because I put up the clapping signal first, and I want to clap too, but I was.
That's okay. You can
clap. There was a question on here going back to that slide from SAMHSA. That wasn't my question, but I do wonder, because SAMHSA doesn't collect data on like fentanyl, for example, I'm curious if what you're seeing as far as different interactions and whether how you would categorize that, or what any of your thoughts that you'd like to share in thinking about our clients.
Go ahead. Yeah, go ahead.
In terms of fentanyl use and meth use, like that, Dr. Myra?
Yeah, or use with, I think, also, I think just like other opiates, or whatever else you're seeing out there, I guess. I'm just thinking there's a lot of, maybe even with the sedatives and things too, there might be some interactions to share.
Oh, yeah. So what we see, what we're seeing is a lot of opiates and stimulants, and then with the stimulants, it's usually meth, occasionally cocaine, and with the opiates, it's usually fentanyl, occasionally other things, and then we do see some benzos, not as much, and then sorry, Michelle, I didn't mean to cut you off.
No, that's okay. Yeah, there's just what people are using has changed a lot in a very short period of time. And, like you said, SAMHSA doesn't even collect data on fentanyl, but yet nobody's using heroin, at least not around here anymore. And so we're a little bit behind as far as the data and stuff that's being collected. Basically what we're seeing in clinic is, there's more people using multiple substances than previously. And it's a lot of fentanyl and meth.
Do we want to pull up that that slide again, actually? Because I think there's another, Dr. Naranjo Rivera had a question about it too. So I'm curious just to visualize it again.
Well, I don't know if Swetha had any more comments about that, like in terms of the psychopharmacology of that.
No, nothing beyond what I already kind of mentioned, as far as you are seeing in your clinical experience, that people are using both of those for whatever reasons, whether it's for managing withdrawal symptoms or for whatever reasons. Yeah.
Thank you.
But here's the slide. I just wanted to pull it up again. And I'm not sure if it is.
And maybe I can read out loud Dr. Naranjo Rivera's question, because yeah, I have the same question. So she said, I just want to make sure I understood the graphs shown. With the co-occurring graphs, are we then seeing that nearly 70% of cannabis users, 68.1%, are also using meth?
Or perhaps it's that if they're using meth, 68% of them are also using cannabis.
That's what I was thinking, but it's hard to, I guess I'm not sure which it is.
Yeah, I think it's the second thing you said, where if they are using meth, then 68% of them are also using marijuana. Just looking at that first bar there.
But the red bar says no meth use. So that's a group. So this is this first bar here is acting like that is 100% of
Is it maybe
marijuana users.
17% of people who have no meth use marijuana, but 68% of people who use meth are using marijuana? Is that what it is?
That's how I interpreted it.
Okay. Like,
If you look at
meth, only 3.4% are using opiates, but anybody who's using meth, about 43.7% are using opiates. Is that how it goes? It seems a little backwards, yeah.
if you look at the numbers themselves and not the percentages, they're opposite. So this first one here is 46.9 million for the red bar and 1.4 million for the blue bar.
Because it's the percentage, it's counting the percentage. So that what that means is that there's many, many more people who have not used. And then, yeah, but that doesn't make sense to me, because then all the numbers of the people who use meth should be the same. Who didn't use any meth.
Right, exactly.
Yeah, and I can send you I have a link here, but I can send you the PDF to send out too, if that will probably have more explanation on their data collection.
Right. And I just can't get it in my head that 68% of people who use marijuana use meth. I feel like that's probably not it, even though that was what I got out of it when I looked at it too. So yeah.
And they might not be using it together either, because the blue box is just for those who've used, maybe they even used only once meth in the past year. So
yeah, that's a good point too, because it says any past year meth use. I want to move on to another question here. So Hannah has a question about beta blockers and stimulants, saying that when a patient is intoxicated or using stimulants, so she's been taught not to use beta blockers or clonidine to bring down blood pressure, because it can sometimes do the opposite. Is this something can you explain, why this happens? Looks like there's differing opinions as to like what should be used in those situations.
I don't have a good answer for this, and I apologize for that, but I want to throw this back to the group, knowing that there's other experts on this call that might have more experience with this.
Hi. So can you hear me? So we were taught not to use beta blocker, by one doctor. I've been taught not to use in emergency situations, heart rate's really elevated, blood pressure really elevated. You don't want to use beta blockers or clonidine because it can sometimes have an opposite reaction or put stress on the heart, and you're best to use a benzo to bring down blood pressure in an emergency situation. But then I've seen a lot of doctors prescribe medications like propranolol or beta blockers for anxiety in patients who are actively using meth. So I was just wondering if this could be a risk, or if it's something that we should be looking out for. If the patient is feeling anxious, they use the beta blocker. Could this put them in, could it lead to, I don't know, any problems? And then I've read some research that varies, and some doctors are saying it's really not as big of as a risk, especially with the clonidine. So I don't know if anyone knew anything more about that.
I've heard that it's not a significant risk, that it's more of a perceived risk than a real risk, but I don't know the research or anything like that.
Yeah, the only thing I'm thinking of is with those medications, if someone is taking them and then they're stopped abruptly, there's a risk of reflex tachycardia, which might be even worse if someone's using stimulants as well. But again, I'm not sure exactly how that might play out.
That's a good question. Thank you, Hannah.
I also just did a quick, I hadn't heard about this before. I thought it was super interesting. So I did a quick search, and I'm also seeing some articles say that I guess clonidine is sometimes used as an add-on therapy to treat ADHD with stimulant medications because it increases the effectiveness of the stimulant ADHD medication. So maybe with, non-prescription meth use, it does something similar, that it just, for whatever reason, increases the activity of it.
That's really interesting. Does anybody else have anything? I'll throw something out there. I would like to know kind of the pharmacology behind, what's going on then when folks add in gabapentin to all of this.
Yeah, I think that is interesting because gabapentin is kind of like, we're doing a lot of different things in the brain that is not super clear as of yet, at least, yeah. And so it's really, I don't know. I feel like I've seen it used to kind of manage withdrawal symptoms sometimes. And so how does that, kind of the opposite effect potentially compared to stimulants? But yeah, I'm not sure. What have you seen, I guess, just like anecdotally when people are using that?
From our patients, definitely they use gabapentin to manage their withdrawal symptoms, but for opiates, meth, and alcohol, for sure. And I know that in the context of detox, gabapentin is often helpful as for like things like benzos and alcohol, because it can also mitigate the risk of seizures. And gabapentin has a role in a lot of different controlled substances that people take, for recreation. So I think, and it's very, very interesting. It just seems to be in every pathway, and it mitigates the negative, specifically the negative effects of withdrawal. So like, yeah.
So I guess I kind of think of it as like a catalyst, when you mix it in with something, it kind of changes things a bit. So you had the slide with opiates, and so opiates act on the GABA receptors, what does gabapentin do to the GABA receptors?
Sorry, I was trying to pull up my slide here. You are quizzing me on my pharmacology that I don't know.
Sorry.
No, it's a good question. And I think I had looked it up recently, and like you'd think that it would work on the GABA receptor, but I don't think it does. I think it
does.
Uh-oh, Dr. Robbie, did we lose you?
Yeah, sorry, my internet is a little bit funky right now. So my understanding is it's like it inhibits the GABA receptors. That there's a whole GABA, if you look at the GABA, I'm sorry, I'll see if I can find it.
I know there's other pharmacists on here. If anyone else has a good answer, I'm very curious to hear.
Lucas, I see you unmuted. Do you have some info for us?
Yeah, I was just kind of gonna verbalize my thought process, but I mean, we talked about gabapentin being or GABA itself being an inhibitory neuron. So I was thinking gabapentin would increase the effect of a GABA synapse, but then a quick search on micromedics says no to that. Says gabapentin and its metabolites do not bind to GABA A or B.
Yeah.
The mechanism by which gabapentin exerts its analgesic and anticonvulsant effects is unknown.
Yeah, that's
Like,
kind of what I was thinking too. Go ahead, Michelle, but I found a picture I can talk about too.
in like an inpatient setting, I've seen how taking gabapentin with methadone or with other opiates can increase the sedative effects, and I'm not as clear about how it interacts with meth and what patients experience when they use gabapentin and meth. That's not really a question, it's more of a, somebody can enlighten me.
It might like modulate different dopamine release or serotonin release. Let me share this. I don't know if this is coming up. Yeah,
We can see it.
okay, which kind of helped visualize it for me a little bit, of gabapentin binding to this calcium channel, which is like once that channel is changed with its pH levels and so on, it might release some signaling to its neighboring neurons here. And that's how it is kind of conducting nerve conduction and so on. I don't know that answers your question, but this is part of what it might do.
I mean, I think it's, we all recognize that it does a lot of things, right? And that's,
Yeah.
It does a lot of things, and a lot of people like it for different reasons. And it certainly, when mixed with other things, really has a different effect. Does anyone have any more questions? Feel free to raise your hand or just unmute yourself and start talking.
I have a question, but I mean, it's a question that is more of a curiosity, so I can definitely take this offline, but just knowing that like the medications like or some of the different drugs that you're talking about are used for medicinal purposes. I should probably know this, but like how, like for methadone, for example, is that like the medication or how does that work? If you could just explain briefly as a treatment.
Yeah, so it is working similar. I mean, it's working similarly to other opioids like fentanyl, heroin, morphine, and so on, but it's binding to that opioid receptor for a longer amount of time and kind of like giving that almost like basal background level of opioid activity to help reduce any kind of withdrawal effects, is how I understand it to be kind of working and helping with treatment use or treatment.
And it also, for some, well, for like heroin and maybe not fentanyl, but it kind of blocks, like once you're at a, a certain dose, then it blocks the effects almost. I'm not exactly sure how that works, but it does.
I believe it has like a higher affinity to the receptors and that sort of thing, right? And so we do have an echo of, I think that talks about kind of the difference between methadone, Suboxone, and naltrexone, and how they're all used for opioid use disorder, but in very different ways, and they work very differently. I find that to be really helpful. We have just a few minutes left. If nobody has questions, we did want to kind of go through or just try to chat very briefly about some of our survey questions and things that we were wanting to know from you guys. So what I pulled up here is just three things that we were hoping we could just chat about kind of as a group for the last few minutes. And so the first one being, what are some of the barriers to expanding access to medications for opioid use disorder within your facility or organization? I'm not sure, you know, where everybody works. But does anybody have, you know, anything to say, any thoughts on this?
I can share a neighborhood perspective.
Yeah, that'd be great.
So at Minnow Bedizthawin development, we have 110 units. We have a daycare and have the wellness program. We do have the IOP program over here, but right now, other than like a harm reduction group, we really don't have a lot going on for the treatment specifically, if thinking about like a medication specific treatment. But we have had a recent, the city has deemed the area a drug-free zone. And if you come up into the area here, like we have a syringe drop because of the shelter. I believe the shelter initiated having that put in across the street, which is actually on right next to our building in the garage. So there's a lot of people kind of coming into our block to use, and you know, gang violence and things like that is taking place. So I believe that came about, that ruling, because of safety of the residents and concerns that they had. I guess there were some elders that had moved out of the building. But I recently rode to on the light rail, which is like right next to us. And the Franklin light rail station is like overrun with drug use right now. There's like needles everywhere. And I almost witnessed 2 people die. One person was walking on the tracks, like trying to pick up needles. Another person was, you know how on the light rail it says don't lean against the doors because you could fall out. There was somebody carrying foil, which I need a lesson on, like what they're carrying in the foil, if that's meth or what that is. But he was like falling against the door. Luckily he didn't fall out, but it was just really mind-boggling to kind of see the amount of use in that for that. The city to deem it a non-drug zone, because, you know, different orgs come up here and do deliver different services, like safe injection type services. So I'm curious if anyone has any thoughts about how they've overcome kind of competing demands within their communities.
That I think that kind of leads into like the last question on here is like, you know, what kinds of topics would you like to see discussed? And I think that's definitely something we could try and kind of talk about. What are I mean, you know, there's a lot of great things happening in Minnesota and outside of Minnesota, and what are some organizations doing with these situations? I think that's I will definitely write that down.
I'm a little unclear of what that means to be a drug-free zone. I mean, what does that actually mean? And does that actually mean that there's more drugs in that zone? You know, or does it mean that there are more efforts to clean up needles? I'm curious as to what that means.
I think it's an effort to clean up the area because it is such a high drug use area. And the shelters right across the street, there's tons of people coming out using right on the street. So I think the idea, and I don't have a lot of history or information on this, so I am looking into it a little bit more, but like, yeah, what does it mean? Does that mean orgs can't come up and deliver these services to people who actually are sleeping overnight right there? It makes most sense to do that, and also dropping syringes. So are they going to move that because that is bringing people into the neighborhood or people coming out of the building who can drop them as well? So are there syringes? So I agree. Like, I think it's extremely confusing, and different agendas are just conflicting here. And I don't know how we kind of, as partners, kind of move forward and continuing our services and supporting people who are struggling with opiate addiction, but also keep people safe, or a perception at least of like not having the gangs and the guns and the things that come along with that outside of the building.
The first thing I thought of when I heard that it's now a drug-free zone is that it's a way then to more quickly and easily arrest or remove folks who are using or have something on them.
Yeah.
They're not doing it. I think it's just their way of police presence to justify bringing police more often in the area, because people are still actively using, and I see even with police around, and I'm not seeing arrests.
I think that I just looked it up briefly, and it says it means the penalties are stiffer. That's what it means.
Yeah, it's usually,
So
a way to
I
care
don't
people.
I don't see anything about more resources to the area. I don't even see anything about a bigger police presence or picky. I just see the penalties are stiffer.
Yeah, and maybe it's for a lot of the drug selling that's going on and less of the using. I don't know. I haven't seen it over here as often. I see people that are actively using and police around, and I'm not seeing arrests. So I'm wondering if that's a space too, by the light rail where people can sell, where, people are targeting, because you see more cars out here as well during certain times of the month, the beginning of the month, targeting, I think, populations as far as making it more of a selling or a hot spot for selling.
It looks like we are out of time.
There is one last question in there.
Yes. So I did respond to Valerie. And so basically looking for specific culturally specific treatment for the first time ever. Somebody is at a point in their recovery that they are ready to start engaging in some more formal stuff. So that's awesome. And I will have some of our chemical health folks reach out because there is a whole host of options. Thank you, everybody. We will see you on the 17th.